It's my pleasure to co-share this session with my dear professors. I would like also to congratulate Dr. Professor Halafawi and all the team from Qasr Aini University with this very distinguished scientific program. It's my honor also to present a very eminent professor in the field of interstitial pulmonary fibrosis. Please, Dr. Sara Tomasetti, we are very honored to have you here among us here in Egypt. Dr. Tomasetti is well known around the world. She is the head of the interventional pulmonary department at the University of Careggi Hospital in Florence, Italy. She will give us a presentation about cryobiopsy, lung and mediastinal approach for the diagnosis of thoracic diseases. Thank you, Professor. Please.
Sabah here. Sorry, that's the only word that I've learned so far. I'm truly honored to be here, and it is a pleasure to have the chance to present at this important Congress. So please allow me to thank all the people that permit this to be possible, starting from Tarek Safat, the president of the society, the president of the Congress, Ashraf Athem, and the chairman of the organization committee, Ahmed Halafawi, and all the committee, and of course my chairs that are here present to help me in this in the presentation of this topic. And I cannot not mention Ahmed Karib for his continuous support and help in all the organizational stuff. We will touch the topic of cryobiopsy, looking at lung and mediastinal approach for the diagnosis of different thoracic diseases. This is my conflict of interest. Let's start with some technical aspects. We know that cryobiopsy requires minimum safety standards, and we should have in mind that we need an appropriate guide. Fluoroscopy is fine. We need preventive use of bronchial blocker for bleeding. Patient should be intubated, and the optimal sites for cryobiopsy is right beneath the pleural. And this is very important to minimize the risk of bleeding. Intubation is required. There are in the literature few case reports and small series proposing cryobiopsy without intubation, but this can still be very dangerous for patients because in case of severe hemorrhage, controlling bleeding can be very challenging with no intubation. Which tube should we choose? Well, I have an extensive experience with intubation or rigid bronchoscopy. I just did yesterday with some of your colleagues at cryobiopsy using the orotracheal tube. Of course, it is very easy to do, and so it was very easy for me to learn the way you do it. But please let me focus on some important advantages for the use of rigid bronchoscope. First of all, with the rigid bronchoscope, you have the control of the airway. Second, it is easier to maneuver the Fogarty balloon in any segment you want to reach. You have a large size. I use a 14 Storz rigid, which allows you to put inside any kind of aspiration, multiple Fogarties in case of severe bleeding. And of course, it is an occasion to train your team, because if you use rigid bronchoscopy also to do diagnostic, then you have a volume of activity that really allows you to train many of your team members. And when you have to face an emergency, when they are on call, they're more trained, more prepared. So this is just, a proposal. Of course, there is nothing definitive, and many centers around the world actually still use and will continue to use, of course, the flex tube. Bleeding risk with cryobiopsy is increased compared with transbronchial biopsy, and this is something we should have in mind clearly. This has been proven for lung tumors, ILD, not really for peripheral lung nodules. Overall, if we look at the incidence of severe bleeding, which are the bleeding that can cause the death of your patients, well, the pooled estimate in this meta-analysis is below 0.5%. But all the published papers were performed in centers where the equipment was appropriate and the training was done. So around the world, of course, there are many centers that may try to do it in a different way, and this can be dangerous. So bleeding, severe bleeding, is the real danger of cryobiopsy, and we need to do it in the appropriate way in order to, contain the risk. And if it is done in the appropriate way, as you can see, the severe complications are very low. The other complication is pneumothorax, around 10%. 2/3 of them requires chest tube drainage, not really a big issue. Size and freezing time. Of course, now we have the single-use ERBE that integrate the pluri-use armamentarium. So we have the 2.4 millimeter and we freeze around 5 seconds. 1.9 and 1.7 we freeze around 7 to 8 seconds. 1.1 millimeter, the smaller one, to get larger sample, we freeze around 10 seconds. We don't really have very good randomized control data comparing the new probe to the old probe. This is something that we can work on in the field of research. And the new 1.1 cryoprobes comes with the sheet. And so for peripheral lung nodules, many of the studies that you will see are performed with the disposable sheet cryoprobe. But of course, it can also be used without the sheets. It is important to standardize the technique. We're not there. As you may note, the size of the cryobiopsy changes significantly between different centers. And when you have a small cryobiopsy, then you don't have good results, and your diagnostic yield will be similar to that of transbronchial cryobiopsy. We still don't have convincing data suggesting how many lobes and how many samples. From our study, we suggested to biopsy at least 2 different segments or 2 different lobes with at least 3 samples. And that should be around 5 millimeter diameter minimum each piece. The diagnostic yield can increase and the complication, particularly pneumothorax, can decrease with experience and with training. But again, this is an area for research because we have very limited data. And another interesting area for research in ILD is the use of new guiding systems such as radial e-boost, electromagnetic navigation. This was our contribution to the field, CT, fluoroscopic guidance, combined CT, confocal laser endomicroscopy, and optical coherence tomography, which are currently under studies. So cryobiopsy nowadays has at least 2 well-established roles. One is the treatment of central lesions, debulking, cryotherapy. Other colleagues will speak about it. The diagnosis of ILDs, which have been endorsed by the recently published ERS guidelines. And then there are some emerging roles for the diagnosis of peripheral solitary nodules, mediastinal disease, and pleural disease. We know that compared to regular forceps biopsy, cryo increases the diagnostic rates of lung tumors, solitary pulmonary nodules, mediastinal disease, not really in pleural disease. For peripheral lung nodules, there are several applications, and this is an example of how cryobiopsy, in this case combined with the ultra-thin bronchoscope, and Professor Gasparini will talk about this, can allow the diagnosis of very rare tumors, such as myofibroblastic tumor and other entities that in the pre-cryobiopsy era could be diagnosed only by surgery. Cryobiopsy allows all immunohistochemical and molecular studies, and this is another example of this. a case of miliary adenocarcinoma, difficult to diagnose by transbronchial, but nicely established by cryo with genetic testing showing the mutation that then led the treatment of these patients. We really don't have much data on the potential of cryobiopsy for molecular pathologic diagnosis, but there are some studies in the literature suggesting that cryo is superior to regular transbronchial biopsy for the definition of the molecular profile of lung cancer. Of course, we know that for peripheral lung nodules, it is feasible. This is a contribution from your colleagues from Egypt in collaboration with the Barcelona Center. They nicely showed that avoiding cases in which they were seeing vessels in the ibus, they performed cryobiopsy that had diagnostic accuracy slightly superior to that of transbronchial biopsy. Sorry, we had some problem with the graphics here. There were some additional data basically showing that with cryobiopsy you can have larger specimen with lower necrotic tissue, and so overall the diagnostic sensitivity and accuracy was better. I'm afraid it is also stuck. Thank you. We have already said that. Ultrasound-guided cryobiopsy for peripheral pulmonary nodules. These are all with regular flexible bronchoscope. I will not touch the ultra-thin topic. This is this very small cryo. With the oversheet, it was safe with no complication, only one moderate bleed, larger mean area of the sample, but no significant increase of the diagnostic yield. This is mainly due to the limited sample size of this study. Similarly, this prospective Chinese study showed a good safety profile and an increase in the diagnostic yield, but again, not statistically significant. This systematic review basically confirmed the same impression. So the diagnostic yield was slightly increased by cryobiopsy, but any study and not even the meta-analysis could reach a statistically significant difference in lung cancer. However, there is only one randomized control study in this meta-analysis, and the data on molecular diagnostic yield are lacking. So there is a lot to do. Many centers are focusing on implementing cryo with novel guiding techniques, such as electromagnetic navigation, of course. This is the larger cryoprobe, 1.9 millimeter. Again, safe with a diagnostic with only 5 mild or moderate bleeding, and with a diagnostic yield significantly superior to that of transbronchial forceps, 69 versus 38%. They also used dye marking to guide a more conservative surgery, and the new lung vision system with a diagnostic yield of overall 77.8% that again was superior compared to regular forceps biopsy. So at least using novel navigation system, some increase in the diagnostic yield has been shown for cryo, and this study focused again on navigation, but I have extracted the data on the characteristic of the nodules, and you can see that cryobiopsy was particularly efficient compared to regular forceps for nodules less than 2 centimeters and for nodules that were eccentric on radial ibus. Again, this is the Illuminate, the ENB digital synthesis system. Unimodality, not really superior. Multimodal approach definitely could increase the diagnostic yield up to 93% of cases. And the new application, of course, is the mediastinum. We have just started. We've done 5 cases so far. This is an emerging and promising technique for neoplastic and non-neoplastic disorder. In this Chinese study, which is the largest published today, there is not really a great difference when we're talking about metastatic lymphadenopathies for the morphologic diagnosis, but there is a superiority for uncommon tumors, benign disorders, and most importantly, for immunohistochemical molecular staining and for gene mutation PCR testing. And lymphomas. So when it comes to difficult diagnosis, benign diseases, and molecular stainings, ABUS cryo seems to be significantly superior. For pleural cryobiopsy, well, we really have few data on this topic. This was a randomized trial that compared cryo versus forceps biopsy in semi-rigid thoracoscopy. There was no significant difference with the 2 methods, and this has been also shown by this meta-analysis. The pieces are significantly larger and qualitative better, no difference in terms of safety. Compared to semi-rigid pleuroscopy, cryo may be superior when the thoracic wall is thickened, for example, in mesothelioma, helping to get deeper samples, or in rare conditions such as lymphomas and other granulomatosis. But of course, the true space for cryo in thoracoscopy is trying to reach the lung, because we know that very well that for the pleura we can do rigid thoracoscopy and we can have a very large sample just using the rigid forceps. So this is probably why the role of cryo in that field is not so expanding. In ILDs, I'm not taking your time talking about the established use of cryo in ILD. We know very well that it is now used and endorsed by guidelines, and in the future we will have an increasing use of this tool also in other conditions such as lung transplant surveillance, possibly connective tissue disease ILDs. This is a field in which the evidence are really lacking on tissue. ILAs, which is an emerging issue, particularly in the countries that are participating in CT screening for lung cancer, and of course post-COVID fibrosis. And in more severe patients. In the era of precision medicine, cryobiopsy will give us the information that we will need for molecular studies, and we know how much this is important to treat lung cancer patients right now. And it is also important in the management of some selected interstitial lung disease, such as this case of Langerhans cell histiocytosis with BRAF mutation. We have several studies going on looking at the profiling of fibrotic interstitial lung disease thanks to the tissue that we can provide with cryobiopsy. Of course, for the diagnosis of interstitial lung disease, there is a clear superiority of cryo in terms of safety. The diagnostic yield is slightly lower, 80% compared to above 90% for surgery. The recent guidelines endorse the use of cryo instead of surgery, also in patients who are possible surgical candidates, weighting the fact that with cryobiopsy you can reduce the risk for your patients, including the risk of mortality. And of course, the procedure has also lower costs. So compared to surgery, you now have a technique with a lower mortality that can be done in an outpatient setting, lower adverse events, lower costs, endoscopy settings, no need for the operatory room, and you can, of course, biopsy a broader spectrum of patients that with surgery would not be accessible. This is, again, a recent cost analysis and complication analysis that showed for awaked VATS, which is the emerging new technique for lung biopsy, that the diagnostic yield of cryo compared to awaked VATS was inferior, but in terms of safety, we had lower. For the complications that were encountered, they were all in favor of cryo. Lower persistent air leak, lower needs to discharge the patient with the Heimlich valve, significantly lower duration of hospitalization, and significantly lower costs. So just to touch the conclusion, cryobiopsy for mediastinal and lung diseases has a consolidated role for central airway lesion, blood clot removal, foreign body removal, and of course for the diagnosis of interstitial lung diseases. The field is expanding toward new entities and with new guiding system. There is a growing body of evidence on the utility of transbronchial cryobiopsy for the diagnosis of solitary pulmonary nodule, and of course, the field of thoracoscopic use of cryo is still under development. Thank you very much for your attention.
I would like to thank Professor Dr. Sarah so much for her comprehensive about the use of the cryotherapy and the contraindications and the indications and the complications we may suffer, because sometimes we are fancying the procedures, but we know to the depths of it and the different uses as well. Thank you very much.
Thank you.
Any questions? Okay. Thank you.
Thank you. Okay, next speaker.
Yeah.
It's my great pleasure to present my dear colleague, Spasogej Popovic. He's an assistant professor of interventional pulmonology in Clinical Center Serbia, Belgrade. He's a well-known figure in interventional pulmonology. He's a dear colleague to me and to all the members of the society. Since several years. He's going to speak today about the cryo use in central tumors. It's a great pleasure to have you, as usual, in Egypt, Popovic.
And of course, it's a great pleasure to be again in Egypt. Practically, I'm feeling like Egyptian Serb or Serbian Egyptian or something like that. So I'm practically home here. And I would like to thank the organizational committee for inviting me. It's such a pleasure and honor to be here. Cryotherapy in central airway obstruction has its direct and indirect implications. You will see that we all know that cryotherapy is the therapeutic application of extreme cold for the local destruction of living tissue. And we need to understand few terms to understand better the terminology of the cryotechniques. First, cryoablation or cryotherapy is application of alternating freezing and thawing cycles to induce delayed cellular necrosis and tissue destruction. Then the cryorecanalization is the technique of debulking of the exophytic tumor by repeated freezing and removal, leading to immediate restoring on airway patency. That means it's a fast technique. And the cryoextraction is using a cryoprobe to freeze material to remove it from the airway, like foreign bodies, mucus, blood coagula from the tracheobronchial tree. The mechanism of action is Joule-Thomson effect, very well known, and we use cryogens. Most of the time either nitrous oxide or CO2. So what is the basic principles? How cryo works actually? First, the direct effect is increase in size of intracellular ice crystals, which leads directly to cellular dehydration by means of increase in the concentration of intracellular electrolytes and denaturation of membrane lipoproteins, resulting in cellular swelling and increased permeability. So that means it's a direct effect is the cell death, necrosis. But more interesting thing, and which has an excellent potential for use in future cryotherapies, in the future for another use of cryotherapy, is that apoptosis, reversible cell damage around the necrosis. Around tumors, cryotherapy causes anergy and clonal deletion of the tumors, and also non-tumor cells, fibroblasts, which is good for benign stenosis, causes T cell activation and proliferation, and so in a way it has immunomodulatory effect. Like you put it on a tumor, in the center of the tumor there is necrosis, around the tumor there is apoptosis, but during that apoptosis, some kind of process like vaccination for tumor is taking place, and that has immunomodulatory effect and can be used for therapy. And of course there are other effects, vasoconstriction, this is initial phase, then modification of vascular endothelium, increased permeability of vascular walls, increased blood viscosity, lower intracapillary hydrostatic pressure, decreased blood flow, and which leads to the formation of platelet plugs and thrombosis of the feeding vessels. So this is another type of necrosis, not by direct effect on the cell. It's a microvascular effect. It is ischemic necrosis. Ischemic necrosis is good, but it is also can be bad when we are doing cryotherapy in the central airway, because it can cause delayed bleeding. So the temperature needed for a lesion to be destroyed is between -20 and -40 degrees Celsius. Freezing to -40 or below at a rapid rate results in more than 90% of cell death, and in cryotherapy, the tissue should be thawed slowly by changing freezing and thawing cycles. It's a slow technique. It takes some time for the full effect to tissue to occur. Freezing effect depends on time of application, the pressure of the tip of the probe, the type of tissue treated, and the amount of tissue destroyed depends on calling and thawing rate, the minimal temperature achieved, the water content of the cell. So we are dividing tissue into cryosensitive and cryoresistant. For example, there is no point to apply cryotherapy on fibrous tissue, on fat, cartilage, and connective tissue. Indications for cryotherapy is the delayed palliation of slightly symptomatic, mostly malignant central airway obstruction. Or after we can use cryotherapy or as a single modality, or after immediate method use like mechanical debulking, laser, electrocautery, argon, plasma. It is reserved for patients with poor respiratory function, inoperable because of the proximity of the tumor to the carina or comorbidities, and airway obstruction due to benign endotracheal or endobronchial lesions. And yes, cryotherapy can inhibit the growth by inducing apoptosis of the fibroblasts. So its potential use in benign stenosis is, a matter of some studies. Some studies are taking place studying that. And cryorecanalization can be immediate. It's an immediate procedure for endoluminal tumor debulking. In patients who cannot tolerate lower FiO2 or patients with pacemaker, for example. But it is usually used to bridge the gap between some kind of definitive solution, chemo, radio, or immunotherapy, before something else starts to work. And cryoextraction, foreign bodies, mucus plugs, or blood clots. All contraindications for cryotherapy is extramural compression on the airways. If stenosis is mixed, then we can treat intraluminal component, but extramural compression is not the indication for cryotherapy. And all contraindications to bronchoscopy and sedation. Also, it's cryotherapy, as I already said, it's not used for immediate recanalization in significant airway obstruction with stridor or to stop massive hemoptysis. It may be complicated by post-procedural edema or delayed hemoptysis or necrotic tissue formation after cryotherapy that can lead to significant post-intervention airway compromise. What kind of machines do we use? We use this cryo machine with console and gas tank and cryo probes. They are flexible and rigid cryo probe. My preferred probe for treatment of central airway stenosis is a rigid cryo probe. It can be used for cryorecanalization, cryotherapy of the trachea, and it's kind of different from the flexible probe because it has a mechanism to prevent decompressed gas for returning into the cryo probe. So the towing phase with the rigid probe is shorter. You must take this into consideration when you are doing cryo with the rigid probe. So of course, bronchoscopes, flexible, rigid, we can use flexible through the rigid and combine all techniques. And also we have to be prepared for things that can occur after the cryotherapy, like bleeding. So we need to have argon ready, or forceps to remove tissue if the tissue falls from the cryo probe. For example, if you are doing a cryo extraction and you don't freeze long enough, tissue can drop into the opposite bronchus. Or end up deeper in tracheobronchial trees, then you need forceps to remove it. And of course, we need bronchial blockers for bleeding. My favorite is not hand blocker, my favorite is Carlen's tube. And of course, in rare cases, pneumothorax can occur, so we have to be prepared for that also. So the technique is 3 freeze thaw cycles into on the lesion, then move 5 millimeters and repeat. Freezing times is 3 to 5 seconds, depends on the probe, depends on the tissue hydration. And remember that cryoprobe is freezing 360 degrees. For the bronchial wall lesions, we can put the probe tangentially, and for the lesions which are protruding more into the lumen, probe should be in the central position. And we have to be prepared for the cleanup procedure 1 or 2 or 3 days after to remove the necrotic tissue. And this is how the cryoprobe is put tangentially. As you can see, this is a rigid cryoprobe. You can take the cryobiopsy and do the cryotherapy at the same time. The depth of freezing can be controlled. Minimal complication can occur as bleeding. There is no significant forming of scar tissue after treatment. That is the advantage. With all other techniques, maybe excluding laser, when you are doing when you are reestablishing or you are trying to make the airway open enough for after some kind of fast procedure like mechanical recanalization, scar tissue is a problem, especially in benign stenosis. But after cryotherapy, there is no scar tissue formation. So its potential use in benign stenosis with fresh granulation tissue is good. And this is the post-COVID, post-intubation stenosis, where we put the cryoprobe and treated this fresh granulation tissue. And after the intervention, it's like 1 week after the intervention, we are practically restoring the airway patency. Actually, there is no lesion anymore. So that cartilage resistance to cryotherapy in this case is an advantage because it lowers the risk of airway perforation when compared to other bronchoscopic techniques. This is use of cryo for endobronchial tuberculosis. This flexible cryoprobe is really flexible, 1.9. And in hard-to-reach places, it can be used for other lipomas, endobronchial tuberculosis, or benign tumors of the airways, excluding hamartomas, of course. And after foreign body extraction, cryotherapy can prevent granulation tissue formation. This is the case of tracheobronchial papillomatosis, successfully treated with cryotherapy. So how good it is? There were a lot of studies, but these studies are case studies, observational studies. There were no really randomized control studies to assess the full effect of cryotherapy. But from the experience, yes, mostly in patients with malignant airway stenosis, there is improvement in lung function tests after the cryotherapy, and also the quality of life of these patients significantly improved. Effect on survival of these patients is not so well studied as in other techniques. For example, combination of laser, argon plasma coagulation, stent placement, and intraluminal brachytherapy. So, complications in bronchoscopy are bronchoscopy and anesthesia related. So, if you are doing cryotherapy, hemoptysis is a result of tumor necrosis and delayed hemostasis effect. First, after initial vasoconstriction, the vasodilatation occurs and patients start to bleed some time after the procedure. So in this situation, you need to have your APC machine ready. Also, we need to repeat bronchoscopy to clear airway piling of the necrotic debris in the airway. So to be ready to, if the tissue migrates from one bronchial tree to another, we need forceps to remove this, and sometimes mucosal tear and ulceration and airway perforation can occur, but we are preventing this by controlling the freezing time. Then the position of the probe should be as far as possible from the posterior wall. So in this case, in all these studies, complications were mostly controlled by conservative management, but we should take into consideration these are patients with advanced malignant disease, and mortality may be caused by the disease itself, not the treatment. This treatment is, of course, strictly palliative for malignant central airway obstruction. If everything went well, bronchoscopy 5 to 7 days after cryotherapy, and we are then assessing efficacy and follow up the patient for long term. Cryorecanalization is another technique which is used to remove the large tumor, necrotic tumor for the airway. The one thing, you should see the lower border of the tumor. That's one thing, and the second is actually that the basis of the tumor should not be more than 2 centimeters in diameter. In this case, we combined rigid mechanical debulking and cryo extraction of the tumor, and then treated the base of the tumor with argon plasma coagulation. So, what are the limitations and precautions in cryorecanalization? This we should all the time we should control the retraction force. If you feel that the retraction force is low, you are debulking the tumor. Practically, you should continue. But if retraction force is strong, you are probably pulling the bronchial wall. Then stop, tow, and rigid probe is towing faster than flexible, and you need, as Dimon said, you need to fill the wall when you are doing these procedures. And of course, you should be always ready for complications, to apply cold saline, to press the place of bleeding by rigid bronchoscope, apply tranexamic acid, double lumen tube, balloon blocker, or nafazolin goes with adrenaline or nafazolin on a swab. That's my preferred method of hemostasis. In COVID, we had a lot of complications like this. So the patient has, for example, is on ECMO or has tracheostomy. After tracheostomy, blood is going down into the tracheobronchial tree, and it can be, and after 2 or 3 days, patient is presented with atelectasis, and there is blood clot in the airway. And the most efficient way to remove that blood clot in one piece is cryo extraction. Of course, foreign bodies. When you have foreign bodies that contain water, it's easier to extract them with cryoprobe. But don't touch the wall because it will cause the mucosal tear. So what are the conclusions for this lecture? Well, endoscopic cryotherapy has multiple indications, highly efficient, good safety profile, can be used in malignant and non-malignant airway obstruction, and it is a good alternative or complementary method to other mechanical or hot techniques for debulking of endoluminal lesion. Cryoextraction for foreign bodies that contain water and blood clots, and the future is in the combined modality therapy. But it is not the end. It is actually, with cryotherapy, these methods are only the end, represent only the end of the beginning, because combined modality cryotherapy is entering the medicine. Combining cryoablation with other cancer therapies may create a synergistic anti-cancer effect greater than either monotherapy alone. Cryotherapy targets cancer stem cells and create an unfavorable environment for tumor regrowth and vascularization, so it can potentiate the effect of chemo or radiotherapy. And that immunomodulatory effect I mentioned, there are now studies. First, there were case series. Now there are studies that there are that cryoablation itself triggers an immune response via tumor lysates and can be considered a weak form of in situ cancer vaccination. Also, in some cases, it was also effective in achieving complete response for patients in non-small cell lung cancer who had developed resistance to anti-PD-L1 and anti-CTLA-4 antibody immunotherapy. And the last slide, nanoparticles. Is this a future? Practically, when you put something into the tumor and then combine immunotherapy and cryotherapy, the effect can be greater than either therapy alone. So nanoparticles can help faster ice formation, inducing cellular damage by altering properties of cell membranes, control drug release in those toll-freeze cycles. So we can, at least we can achieve uniform necrosis around the tumor, and therefore the effect of the cryotherapy can be greater. Thank you very much for your attention.
Thank you very much, Professor Popovic, for your talk about cryo for central airway obstruction. And then any question for تفضل دكتور مدحت.
Thank you. But I have one question about the treatment by cryotherapy in the future. If this low can affect the growth of the tumor mass or not? Did you have any study about this?
Excuse me, just to be sure that I understood the question.
Yes, because if the low temperature by using cryotherapy can affect the growth of tumor mass.
Yes, it can affect. It can lower the multiplication of the tumor cells.
Yes, and I agree with this. But did you follow up for this as a line of treatment for tumors?
No, actually, cryotherapy is just in this stage. It's a palliative method. These things on the last slides are the future, and there are very limited experiences how how can all that actually work on in large series of patients. There were not large series of patients, but maybe 40, 50, maybe up to 100 patients were treated with all these combined modalities. But it's a promising therapy. We need more data to conclude that.
Thank you.
Professor Tomasetti, do you like to comment?
Thank you for the wonderful presentation. I have a very simple question. I want to know, based on your experience, when you have to treat the base of a tumor, and you have different tools you have shown us, argon plasma, cryo, which one do you choose, and how do you choose them?
When I need to treat the base of the tumor, I first use some kind of either cryorecanalization or mechanical debulking. When I treat the base of the tumor, my preferred method is argon plasma coagulation. Just to put the probe in the, it stops the bleeding almost immediately. Then I put the argon probe near to the lesion, and actually this argon arch will go to the nearest wall. So it doesn't matter what kind of probe I'm using. Is it straightforward or is it angulated argon probe? If that spark will go to the nearest wall, and I treat this until I stop the bleeding. After a day or two, I am going back into the airway with a flexible bronchoscope to remove the necrotic debris. If there is bleeding present, then I treat it again with argon. My preferred method is argon because it's the shallow depth of effect. I don't like to use laser, especially if the lesions are on the posterior wall. If they're on the posterior wall, I'm very hesitant to use any electrocoagulation or laser because it can lead to airway perforation. That is my preferred method. Of course, when there is an emergent bleeding and you don't have time to put argon probe, maybe we should or just press the rigid bronchoscope to the lesion to stop the bleeding. Or when I'm using argon, I increase the flow in the probe up to 2 liters of argon per minute, and it can blow out blood, so I can see what I'm doing.
There is.
Thank you.
تفضل. Your question? تفضل.
Thank you very much for excellent presentation. My question about the use of cryo debulking for a patient with stridor because of major tracheal or subglutic tumor that causes stridor and respiratory distress. You said not using the procedure in this patient. Why?
In this patient, the second patient, I did a mechanical recanalization because the base of the tumors was more than 2 centimeters in diameter. I prefer to use, when you see a necrotic tumor and see the lower border of the tumor, and you see that the base of the tumor is like less than 2 or less or equal to 2 centimeters in diameter, you can safely use I prefer rigid cryoprobe to freeze the tumor and to remove it. But at the same time, I'm doing this through the rigid scope. If anything goes wrong, if that retraction force is too high, if I cannot remove that, it works only for necrotic tumors, which are full of water. And if I see it doesn't work, I put the rigid scope with the sharp part of the rigid scope, I put it near to the wall. If the cryo doesn't work, I do the debulking and then cryo
mechanical debulking. I have several cases of patient with stridor, subglutic tumor or tracheal tumor actually occupying more than 90%, and successfully removed and the patient saved.
For subglottic tumor, I'm not sure cryorecanalization will work. First, in subglottic regions, there is a lot of cartilage. And these tumors are usually for thyroid either from esophagus or from thyroid gland protruding into the trachea. And for these tumors, I prefer just mechanical debulking and argon plasma coagulation because they're not large and necrotic. This is good for like lower third of the trachea cryorecanalization, in my experience.
Thank you very much.
Thank you very much.
Thank you.
في البداية بحب أقدم بس الشكر لأساتذتنا على المؤتمر الناجح والتنظيم الرائع، الأستاذ الدكتور طارق صفوت، الأستاذ الدكتور أشرف حاتم، الأستاذ الدكتور أحمد الحلفاوي، الأستاذ الدكتور مصطفى الشاذلي. متشكرين جدا على المؤتمر الجميل، المحاضرات الكويسة والخبرات الممتازة اللي احنا بننتظرها من السنة للسنة. Now we will start last lecture in this session. Professor Alex Ruzman, Head of Interventional Pulmonary and Endoscopy Department, University, Slovenia. He will discuss with us thoracoscopic cryotherapy. He will also discuss rigid bronchoscopy in malignancy. Also, he will discuss peripheral bronchoscopy. Cryos.
Dear Chairman, dear colleagues, thank you very much. It's a great privilege for me to contribute to this very important and very well organized Congress. And actually, I'm very thankful also to the organizing committee for their generous hospitality. And before I start, I will just say that this talk actually won't be too long. We are a little bit behind the schedule, and Professor Tomasetti and Popovic practically explained the whole cryobiopsy, the theory, and the practice, and so on. So I will just briefly go for thoracoscopic cryobiopsy, which is actually a small, but maybe also developing field in the pulmonary medicine. Okay, maybe to make the story complete, it won't be actually the comparison of rigid and semi-flexible thoracoscope, but the whole story goes like that interest for cryobiopsy of the pleura actually started when the semi-rigid thoracoscope came to the daily practice. At the very beginning, there was some disappointment with the size of the samples and the diagnostic yield, and it was some general opinion that with semi-rigid thoracoscope, big pieces of tissue required for diagnosis of chronic non-specific pleuritis and mesothelioma are very difficult to be achieved. Because when we compare the size of the forceps, as for example here, the rigid actually are much bigger, and maybe it's also more feasible to take a big sample from the bronchial wall. But later, after the learning curve was overcome and the techniques for taking biopsies also with small and flexible forceps were made better, like for example when we promoted the peeling biopsy, some studies showed that actually samples from semi-rigid thoracoscope were smaller, much smaller than with the rigid forceps. But when we compare the diagnostic yield, and this is what at the end of the day is important, do we get diagnosis or not? Actually, the diagnostic yield practically was more or less the same with semi-rigid and rigid thoracoscope. So if forceps biopsy performs safe and well, why do we need some other techniques? Shall we develop further? Actually, why not? Maybe cryobiopsy could offer some advantages and maybe overcome some disadvantages of forceps biopsy. So if you compare these two biopsy tools, one is forceps similar as in gastroenterology, the other is cryoprobe. At that time when we started, this was 12 years ago actually with our study, there were available 1.9 and 2.4 millimeter cryo-airway cryoprobes. Now there is a new generation of them. Maybe we are a little bit less satisfied because they are more rigid and less flexible, but never mind, for pleural purposes they are more than good enough. Although they are just single use and maybe more expensive. So maybe for the beginning I show our own data on 27 patients. We finished this study almost 9 years ago. The procedures was done with same rigid thoracoscopy from one point of entry. The cryoprobe is used and forceps biopsy as well, and then we compare the samples. In all but one patient, we were able to get samples with cryoprobe. Maybe this was also our learning curve. We didn't actually pull too much in order to not do some damage on the pleura. The majority were male. There was a lot of mesothelioma also in the group, some metastatic carcinoma and very small percentage of benign diseases. Cryobiopsies were performed as per protocol 3 per patient. In group of cryo, in one patient we were unable to get biopsies, but this was one of the first patients. With forceps biopsy, everybody gets 3 samples. And we noticed at the end, when we compared the size of the lesions, that cryobiopsy samples are significantly bigger. Then we divided lesions to flat lesions, for example, chronic non-specific pleuritis, sometimes mesothelioma can be very flat, and to nodular lesions, which are characteristic for carcinomatous lesions. And we found out that in flat lesions, practically the size of the sample is just the same in both, with both tools, but where the lesions are nodular, we were able to get bigger nodules with less efforts in the case of cryobiopsy. So our conclusions were that cryobiopsy appears effective and safe because we didn't have any significant complications, just minor bleeding from time to time. Biopsy specimens were bigger with cryoprobe, but at the end of the day, the diagnostic yields was more or less the same, and that maybe cryobiopsy has some practical advantages in nodular lesions where the biopsies are faster and more simple. As I will show here, the cryobiopsy of a nodular lesion on the pleura. The principle is very simple. We just attach the probe to the nodule, we freeze a little bit, and then we gently pull and harvest the nodule. So the pull should not be too big. And as you see, we are able to get huge amount of tissue. Actually, it's also difficult to extract it from the pleural cavity thereafter. So this is the case of the flat lesion. As you see here, one biopsy was already made in the vicinity. Here is the other biopsy. So in this case, the biopsy samples are not so big, they are not so deep, and as you see, they are actually still large. But with peeling biopsy of flexible forceps, you are able to get bigger biopsies. But in any case, such a biopsy of 5 millimeter big is more than enough for a diagnosis, and it's no need to get bigger and bigger samples. I'll show you some data from other centers who also performed cryobiopsy. At the same time as we started, also the Berlin group also started, and they compared 3 tools, actually, the rigid forceps, the flexible forceps, and the cryoprobe. The results were slightly different in the majority of the cases. In 91% of the cases, diagnosis was able to be made by all 3 tools, but slightly more often in the rest with rigid forceps, and then more or less the same amount of diagnosis with the semi-rigid and cryoprobe. So there were actually some significant differences in diagnostic yield, which is the important thing, but in the size of the sample, the rigid forceps, it seems the one that they used that really produced a big histology samples. At the end, I will also show the meta-analysis just recently published, which also showed already a little bit some data Professor Tomasetti before me. So in the last, I think, 12 years, there were actually 15 studies in the field of cryobiopsy of pleura, which were included in this meta-analysis. And you should be very proud of it because many of contributors are actually Egyptian doctors. 4 studies on cryobiopsy, the pleura, were actually made and published in Egypt. More or less, the studies focus around the size of the biopsy sample, the diagnostic yield, and the complication rate. And the conclusions are that the specimen size is actually significantly bigger than in forceps biopsy. So the samples are indeed bigger in practically the large majority, except one study. The other is that crush artifacts are more common in the forceps biopsy. So cryobiopsy produces more beautiful histological pattern without damaging. And at the end of the day, diagnostic yield actually is more or less the same with cryo and with forceps biopsy. So no bigger advantage here when we want to make a diagnosis of the patient. So my conclusions are, as I already told, that cryobiopsy is relatively safe. Thoracoscopic procedure, no big or common side effects reported in these studies. It provides large artifact-free specimens, and the diagnostic yield is more or less the same as forceps biopsy. So in many cases, there is a matter of preference which tool do you use. Thank you very much for your attention.
Thank you, Professor Osman, for this very elegant presentation. I would like to ask if there are any questions from the floor. Please. Ustaz Muhammad. Yeah, okay. Yeah.
Thank you very much. My question is that do you recommend cryo-pleural biopsy for every patient with pleural disease, with exudative pleural disease, or it is used in certain type of pleural lesions?
In pleural lesions, there are several things which we have to take into the account. The first one is, from the practical point of view, cryobiopsy in the patient which has nodular lesions is much faster and much more simple for me as forceps biopsy. So I very quickly get enough material, and it's nice material for all possible examinations, including immunohistochemistry, NGS, and so on. Proven. The other thing is, since last year or 2 years ago, the Arabic cryoprobe changed the reusable cryoprobe to single-use cryoprobe. So from now on, the cost of the procedure are higher when you use the cryoprobe. And the third thing, which is not so clear yet, is the field of tuberculosis. It seems that there are no problems to show that tuberculosis, to show the granuloma in the histology, to show the bacilli into the sample, also to make amplification gene expert test. But there are some problems with culture of tuberculosis, which is frozen tuberculosis bacteria, which actually is important to make the antibiogram at the end.
دكتورة صباح تفضلي.
Thank you for your elegant talk. I have two questions. The first one, what about the role of cryobiopsy in diagnosis of cases of malignant pleural mesothelioma? Is there an advantage for cryobiopsy over the conventional forceps biopsy in diagnosis of mesothelioma? This is my first question. The next one, is there a good role for cryospray in treatment of malignant pleural diseases, as we have known that cryo technique have an immune modulatory effect? Can we combine the cryospray with treatment, chemotherapeutic drugs, or whatever?
Mm-hmm. So thank you very much for your questions. The first one is if cryoprobe biopsy has advantage in mesothelioma. Actually, I don't really know because there are not many data about that. But from my personal experience, it's not very difficult to biopsy mesothelioma, even with the forceps nor with cryobiopsy. The problem sometimes is when some cases of mesothelioma, we also find the pleural plaques on the thoracic wall, and some beginners try to biopsy these plaques. But these plaques are no good for diagnosis. These are just a sign of asbestos disease of the pleura. We have to biopsy the soft tissue, so mesothelioma tissue. So it's a matter of preference. I think that with both techniques we can get big and reliable sample. The second question was cryospray. There were some reports about treatment of the pleural malignancy with cryospray, but I think at the moment there is not enough data to really recommend it, because there was more or less case reports, and the safety of the procedure can be actually shall be assessed more. It's also maybe a bit risky. Sorry maybe you have some experiences. Actually, I don't have this cryospray, but when we try to liquefy the gas into the closed space like pleural cavity, there's a danger that sudden rise of pleural pressure makes some problems as well.
Regarding mesothelioma, I was not asking about the pleural plaques. I was asking about cases of mesothelioma, early cases when the thoracoscopy finding showing not nodular pleura, showing just thick pleural peel. This fibrotic pleura may be difficult to reach a diagnosis by the forceps biopsy. Most of the literature mentions that the depth of the cryobiopsy is much more better than the forceps biopsy. Presented by the fat cells. I know that your study showed that no difference between the forceps biopsy and the cryobiopsy regarding a fat lesion. The nodular pleura more better in the cryobiopsy. But I was asking about when the pleura is just thickening of the pleura, no nodular lesion on the pleura.
So if the pleura is just flat and hard.
Yes.
Yeah, so flat lesion, so-called, yeah. Mesothelioma can show on different varieties. So not all the mesothelioma are the same morphologically. So some have a lot of nodules and so on, but the other sometimes can really resemble the chronic inflammation of the pleura. In that cases, I agree that it's slightly more difficult to get biopsy sample, but it's feasible with both techniques, forceps and cryoprobe. Maybe you spend a minute or two longer, but at the end, the samples are there. So, in my experience, always it's possible to get a decent sample, even with forceps and cryobiopsy. So, in the case which I showed there was a chronic non-specific pleuritis. The biopsy sample are a little bit smaller, big, around 5 millimeters big. And I agree, they should be a little bit more deeper if pleura is thick. How we assess when the sample is deep enough that we go through this just fibrin layers to the real tissue, we shall see some minimal bleeding after biopsy. If there is no blood after biopsy, we are too shallow. So we have to get a little bit deeper. When we hit the vessels and there is some small bleeding after biopsy, then we are deep enough.
Thank you.
Thank you very much, and thank you very much to our dear international guests for their important insights on cryobiopsy and cryotherapy in pulmonary medicine. We are already behind schedule, so I would like to welcome my dear professors for chairpersons for the next session, Professor Intisar El Sayed,